Welcome to another Critical Care lecture series. In this session, we'll be discussing critical care obstetrics. My name is Bob Gibson. I'm an acute care nurse practitioner. I have no relationship with industry. I have no financial disclosures to report. Clinicians seem to love or hate obstetrics. For folks that dislike critical care obstetrics, I feel it's more fear-based than anything. And the one way to conquer a fear is familiarity, and that's why we're here today. Is crossing the specialties of obstetrics and critical care important? I say yes, because despite worldwide pregnancy, mortality, and morbidity going down, mortality and morbidity is actually increasing in the United States of America. There's some signals showing a social, economic, racial disparity as a possible cause of this. Another suggestion is the high rate of C-sections in the U.S. This leads to more hemorrhage and placenta implantation disorders. Let's take a closer look at how we can improve outcomes in critical care obstetrics. Let's discuss the objectives of today's session. The focus of this lecture is going to revolve around the first three items. First, we're going to discuss physiological changes in pregnancy. These changes allow for fetal development and protection. It allows mom to compensate for new demands, and it also prepares for labor. We're then going to discuss some safety when it comes to taking care of an OB patient. Then we're going to focus on the ICU toolbox for taking care of obstetric patients. These are common obstetric interventions that we do in the ICU. With the remaining time, we're going to go ahead and take a look at some of these disease processes: hemorrhage, Preeclampsia and Eclampsia, the HELLP syndrome, sepsis, venous thromboembolism, and lastly, amniotic fluid embolism. I'd like to point out that critical care obstetrics is normally taught in a 2-day course. This webinar is planned for under an hour, so I really want to highlight that this is an intro to critical care obstetrics. Before moving forward, let's catch up on some common OB terminology and concepts. The average gestational age is about 40 weeks, and that's from the first day of the last menstrual period. Again, that's referred to as the gestational period or gestational age. There's also a conceptual age, and that's the age that occurs from conception or implantation, and generally this falls about 2 weeks behind gestational age. Abortion is defined as either the spontaneous or surgical means of a termination of a pregnancy before 20 weeks. And then extrauterine viability, that is the age in which a fetus can survive outside of mom, is approximately 24 weeks, but this can range from 22 to 26 weeks. We know that the first trimester ends at 14 weeks, the second trimester at 27 weeks. Full term is between 39 weeks and 0 days and 40 weeks and 6 days. Fundal height can give us a good predictor of where the pregnancy is. At 12 weeks, the fundus is just above the pubis symphysis. At 20 weeks, the fundal height is just about at the umbilicus, and at 36 to 38 weeks, the fundal height is at the xiphoid process. The GPA system is a simple way to describe pregnancy history. G being gravida or pregnant, P meaning parida, that is a live birth, and then A is abortus, which is the termination of a pregnancy. Examples would be G2P1A0, that is a woman that has had one live birth and is currently pregnant. Another example would be G2P0A1. This would be a woman that is currently pregnant and has had one abortion. Let's take one more look at fundal height. To be more concise, fundal height is defined by the distance between the pubis symphysis and the top of the uterus. So as you can see, at 12 weeks, the fundus is just above the pubis symphysis. At 20 weeks, it's at the umbilicus. And at 36 to 38 weeks, it's right at the xiphoid process. Now we're going to get into the bulk of the lecture and discuss physiological changes of pregnancy. We're spending the majority of our time on the cardiovascular changes, followed by pulmonary, airway, renal, gastrointestinal, and hematological. Unfortunately, for time's sakes, we're not going to discuss the ureteroplacebo physiology and development. During pregnancy, we know that the blood volume can increase to as much as 50%, and this seems to peak around the 32nd week. To translate this into a volume for an average-sized woman, this is an additional 1.5 liters of blood volume. And this allows for increased perfusion of maternal and fetal organs, and it also allows for the expected blood loss. In fact, a pregnant woman can lose up to about 2 liters of blood before they suffer any symptomatology. Total body water can increase by 6.5 to 8.5 liters, so a mean of 7 liters of additional body water. This decreases the blood viscosity. It causes hemodilution, and this is due to the increased total body water. And then lastly, albumin and protein stores are decreased, and this again is due to hemodilution. But as a result, this decreases oncotic pressure. So in the setting of excess total body water and decreased oncotic pressure, sprinkle in a little extra estrogen and oxytocin, and we have some pretty considerable edema of pregnancy. Another consideration in cardiovascular changes is the increase in oxygen consumption. Mom now is taking care of her own oxygen consumption needs in addition to her fetus. Next is blood pressure. So blood pressure in pregnancy can actually decrease by 5 to 10%. Before exploring that further, let's remember that blood pressure is a result of cardiac output and SVR, systemic vascular resistance. With that said, systemic vascular resistance can be reduced by as much as 20 to 30%. And this is due to progesterone. High levels of progesterone during pregnancy, and progesterone causes vasodilatation. In addition, the placental unit is a low resistance system. It can't auto-regulate. So with the combination of progesterone causing vasodilatation and a low resistance placental unit, the systemic vascular resistance is grossly reduced. And this reduction in SVR and blood pressure seems to return to just about normal around term pregnancy. And now we can discuss heart rate. Heart rate can increase between 15 to 20% during pregnancy. This is significant and something that we need to know at bedside. Next, let's take a look at stroke volume. So stroke volume can increase by 20 to 30%. And remembering a simple definition of stroke volume is how much volume is ejected from the ventricle in one beat. And stroke volume consists of preload, contractility, and afterload. Preload is increased in pregnancy due to the increase in venous return. Afterload is decreased due to the decrease in the SVR, the vasodilatation, and indirectly there's a small increase in contractility. Remembering that cardiac output equals heart rate times stroke volume, it's easier to understand how cardiac output is significantly increased during pregnancy. In fact, cardiac output can increase as much as 40%. And this is easily seen with our formula given that we know that there's an increase in heart rate. We've already discussed is the increase in stroke volume, and this is resultant to an increase in preload, a decrease in afterload, and a minor indirect increase in contractility. So if you have an increase in heart rate, an increase in stroke volume, very easy to see that cardiac output increases. To make things even more interesting, during uterine contraction, we can have up to a half liter of blood bolus back into the central circulation. So this increases venous return. And if the heart is working correctly, anytime I increase venous return, it's going to increase my cardiac output. This is one of the reasons that we can see transient maternal bradycardia during uterine contraction. Let me explain by displaying our formula one more time. We remember that cardiac output equals heart rate times stroke volume. If we increase stroke volume, our body says, whoa, slow down. We can decrease our heart rate to maintain a normal cardiac output. And then in addition to that, when mom actively pushes, cardiac output can increase by another 50%. These are drastic hemodynamic changes that we need to keep in mind. Let's move on to the pulmonary physiological changes during pregnancy. First, let me point out that dyspnea is one of the most common complaints in pregnancy. This makes this a diagnostic challenge, especially in our litigious society today. As fundal height increases, the diaphragm gets pushed cephalad, that is to the head. There's only so much room for the uterus and for that fact for the lungs. This decreases functional residual capacity and total lung capacity of the pregnant woman. We can think of functional residual capacity as a volume of gas left after a normal breath. And even after a maximum expiratory effort, there's also something remaining called a residual volume. If we decrease our FRC, our functional residual capacity, we also direct our total lung capacity. Before moving forward, I have a question I want you to ask yourself. Pregnant women have a significantly increased respiratory rate. True or false? The answer is actually false. Respiratory rate increases just a little, if at all. So significant tachypnea is pathological during pregnancy. As with any critical illness, tachypnea is actually the most important vital sign. Moving on with some more pulmonary changes during pregnancy, we know that there's a minimal increase in respiratory rate. There's an increase in tidal volume. And this is in response to the increased oxygen consumption or the CO2 production of both mom and the fetus. In addition, progesterone is actually a respiratory stimulant and it leaves the mom feeling air hungry, taking larger breaths. Pregnancy causes an increased minute volume, and if there's an increased minute volume, CO2 is blown off more, and this results in a normal compensated respiratory alkalosis. So let's break that down a bit slower by using the formula at the top. We know that minute volume equals respiratory rate times tidal volume. With that, we know there's no or little change in respiratory rate during pregnancy. There's an increase in tidal volume. So according to our formula here, if we stay at a constant respiratory rate but increase our tidal volume, we'll increase our minute volume. If we increase our minute volume, we blow off more CO2, PCO2 drops, and we form a respiratory alkalosis. Let's shift our attention to the pregnant airway. The rate of failed intubation is up to 10 times more likely in the pregnant woman. In fact, the leading causes of anesthesia-related obstetric deaths are failed intubation and aspiration events. Let's look at what complicates the airway in a pregnant woman. There's a total body excess of water, low oncotic protein, and hormonal changes that cause significant edema in the airway. In addition, the oral pharynx has an engorged capillary bed secondary to the increase in progesterone. We also know that pregnancy is associated with weight gain and a worsening Mellon-Potty score. So to summarize, this all leads to an edematous, friable, crowded airway. In addition, there's an increase in restrictive pulmonary mechanics, and this is because of the growing uterus and the weight gain of mother. Due to progesterone increases, there's a reduction in GE sphincter tone, and in addition, the growing uterus mechanically distorts the GE junction, and this sets up for an aspiration event. There's also increase in oxygen consumption because of the fetus, and in addition, mom has a poor oxygen reserve. When intubating, we need to acknowledge and maximize the apnea-free time. We can explore this by looking at this graph. On the y-axis, we see the arterial oxygenation, and the x-axis, we see the time of apnea. The patients involved in the making of this graph were chemically sedated and paralyzed for rapid sequence intubation. Prior to, they received appropriate pre-oxygenation. This graph allows us to see how different populations desat at times of apnea. You can see the normal or healthy 70-kilo patient doesn't start significant desaturation until around the 4-minute mark. Compare that to the obese 127-kilo patient that sees significant desaturation at a bit past 1 minute. We can extrapolate this data to understand how a pregnant woman's weight gain, restrictive chest physiology, and increase in oxygen consumption can lead to a significant decrease in apnea-free time. So when intubating a pregnant woman, we need to take the following into consideration. Pregnant women have a decrease in FRC, functional residual capacity, an increase in oxygen consumption, a decrease in chest wall compliance, an increase in airway edema, increase in weight, and an increase in aspiration risk. We should presume that all pregnant women are at difficult airway. In fact, I only would recommend intubating a pregnant woman if she's at extremis. If there's time, always involve anesthesia. Now let's move forward with some physiological changes in the renal department. It shouldn't be without surprise if our cardiac output increases by about 50% that we have an increase in renal blood flow by just about 50%. When we increase our renal blood flow, we increase our glomerular filtration rate by about 50%. In fact, creatinine should be about half that of normal in pregnancy. That shouldn't be a surprise. If we increase the GFR significantly, we shouldn't be surprised that the kidneys are excreting and filtering out more creatinine, so when we go ahead and measure blood within a pregnant woman, the creatinine is reduced. In fact, a creatinine greater than 0.8 milligrams per deciliter is defined as kidney injury in a pregnant woman. Reflecting back on the pulmonary section, we talked about mom having a chronic respiratory alkalosis, and this was secondary due to an increase in tidal volume and an increase in minute volume. We need to remember that the body is always trying to maintain pH neutrality. So in the face of a chronic respiratory alkalosis, the kidneys are going to prevent the reabsorption of bicarbonate. Bicarbonate is going to be excreted, and then there's going to be a compensation for the respiratory alkalosis. With that said, in pregnant women, a normal bicarbonate level is between 18 to 21 milliequivalents per liter. Now, I want to point out that your EMR is not going to scream at you, this woman is pregnant. An example of this, a normal creatinine for a woman is somewhere around 0.6 to 1.1. However, in a pregnant woman, greater than 0.8 is acute kidney injury. The EMR is not going to change its normal range and highlight you of an abnormality. You need to be an astute clinician and understand the physiological differences in a pregnant woman. Now let's take a look at arterial blood gases. So as most of you know, I'm the first person to tell you stop drawing so many blood gases, stop drawing ABGs and get VBGs instead. But in this case, in obstetrics, all sick mothers get an arterial blood gas. And this is due to several subtle changes in normal range values. In addition, it's also to aid in early recognition of critical illness. We know it's normal for a pregnant woman to have a compensated respiratory alkalosis, but let's review the normal values for arterial blood gas in a pregnant woman. For comparison, in the right column, we can see the normal values for a non-pregnant woman. A normal pH for a pregnant woman is 7.42 to 7.46. Anything less than 7.4 should be considered acidotic. You can see variations in norm for PCO2, PaO2, and our already mentioned difference in bicarbonate. I think one of the biggest things to point out with this is our PCO2. A normal PCO2 is 28 to 32, where normal is 35 to 45. In fact, if you have a PCO2 that's greater than 40 in a pregnant woman, that's indicative of respiratory failure. These differences need to be understood so we can have early recognition of our impending respiratory failure and/or critical illness. Now let's move on to the general urinary system. So we know that enlarging uterus is rising up, is pushing up in the diaphragm, and it's also filling that abdominal cavity. And with that, we can have mechanical compression. Mechanical compression in this specific example of the ureters. In addition, pregnant women are very prone to ureter dilatation. In fact, right ureter dilatation is actually a norm in pregnant women. On top of this, we know that progesterone decreases ureter peristalsis. So this leads to urinary stasis. This can lead to cystitis, urinary tract infections, pyelonephritis, and nephrolithiasis. Now, as clinical care providers, we don't discuss this much, but you really shouldn't treat a urinary tract infection unless it is symptomatic. However, in a pregnant woman that's suffering from urinary stasis, maybe suffering from hydroureter or maybe even hydronephrosis, it's imperative to treat pyorrhea, whether symptomatic or not, in a pregnant woman at all times. Moving on to the gastrointestinal system, we're very familiar with the changes seen here. It's very common for mom to experience abdominal fullness, nausea, vomiting, and reflux. And this is obviously secondary to the stomach being pressured, being compressed by that gravid uterus. It increases the risk of reflux. As stated before, it decreases the gastroesophageal sphincter, and it distorts its structure due to the external compression. This unfortunately increases the risk of aspiration. Some laboratory values to discuss first would be albumin. So albumin is going to be low in a pregnant woman due to the hemodilution that we previously discussed. Remarkably, ELK Phos increase is actually a normal finding in a pregnant woman, and this is because the placenta releases additional ELK Phos. And lastly, liver enzyme should be normal, if not low. At any given time, if a pregnant woman has a transaminitis, this is a red flag and it needs to be addressed immediately, and the differential needs to be sought out. Moving on to the hematological system, some changes worth noting is number 1, hemoglobin level. Anemia in a pregnant woman is most commonly defined by hemoglobin less than 11. And even though there's significant hemodilution, there's an increase in erythrocyte production, so the degree of anemia seen in gestational changes is minimal. The 2 most common anemias seen in pregnancy is physiological dilutional anemia of pregnancy, also known as gestational anemia, and also iron deficiency anemia. White blood cell value is worth discussing as well. Leukocytes are generally elevated during pregnancy, and these can escalate as high as 16 to 18K by term and by labor. So this obviously complicates investigations when looking at sepsis. I would set your red flag value as greater than 20K. No pregnant woman should have a white count greater than 20,000. When it comes to platelets, we might see a small reduction, a mild thrombocytopenia, and this is secondary to the dilutional effect and also to some extent consumption. But platelet levels should always be 100K or greater in a pregnant woman, and if not, critical illness should be sought after. And then lastly, make no mistake, pregnancy is a prothrombotic, antifibrolytic state. Let's say that one more time. A pro-forming clot state and a anti-breaking apart clot state. And why? This is another example of the body getting ready for pregnancy and getting ready for labor. The body is getting ready for the detachment of that placenta and the expected bleeding that goes with that. Now I'd like to shift our attention to OB safety concerns. And from a critical care provider perspective, I think this really revolves around fetal development and safety, drugs, and radiation. Before moving forward, let me take a quote right out of Fundamental Critical Care Support Obstetrics. The woman remains the primary patient, and fetal concerns cannot be allowed to compromise her care. So while we always weigh the risk versus benefit and look for alternative, the end result, the end goal, is taking care of mom. When it comes to drug and radiation, we all know that exposures have the potential to cause adverse effects and congenital defects. Timing has something to do with this as well. If we have the exposure within the first 4 weeks, we have something what is called the all or none effect. That is, either the embryo dies due to the exposure or nothing happens at all and there's no downstream effects. Then we have anywhere from 4 to 10 weeks, and this is the vulnerable period. This is where we're vulnerable for congenital malformations and birth defects. Moving on to greater than 10 weeks, at least the stem processes, organ formations have been completed. So there's no potential for a structural birth defect, but the fetus can still sustain brain and overall fetal body growth issues. So let's move forward to drug safety. So the FDA no longer uses its classification A, B, C, D, and X. Now it's moved to a pregnancy and lactation labeling only. The best knowledge or best facts are listed in these pregnancy and lactation explanation data, and that's for you to consider the timing of the drug exposure, the indication of the drug, and also search for alternatives if appropriate. Clinical PharmDs are a very valuable part of the critical care team all the time, not just during pregnancy, and they can assist us immensely with caring for a critical care obstetric woman. Now let's move on to a little about radiation exposure. So first of all, radiation is measured in milligrays. Exposures to less than 50 milligrays of radiation has no association with birth defect, brain or body growth abnormality, or death. I feel this grid very enlightening when caring for a critical care obstetric patient. We take a look at a chest x-ray. There's very little radiation, and this is a 2 view listed at 0.01 milligrays. We then go to a CT chest, which is only showing 0.66 milligrays. And where you start getting in trouble is the abdominal pelvis CAT scans. We always want to ensure necessity, the need for the scan, the need for the x-ray. We always want to look at alternative modality. So in the setting of a CAT scan abdomen pelvis, instead we might want to use ultrasound or even MRIs. Every little bit helps. We can shield the abdomen, but don't delude yourself. The fetus is still receiving some degree of radiation. And lastly, always consult with the radiologist. Some organizations even have a radiation physicist on staff to help answer some of these questions in caring for an obstetric patient. Lastly, there may be some increase in likelihood to childhood cancer with radiation. However, most of what's available in literature seems to be at higher levels of radiation that's greater than 100 milligrays. Or in some settings, it's really pertaining to high-dose radiotherapy, i.e. somebody getting radiation for oncological issues. Now I'd like to discuss some common tools, common interventions that we see frequently in the ICU when treating a critically ill obstetric patient. We're going to briefly discuss maternal positioning, tocolytics, magnesium, betamethasone, and uterotonics. First, I'd like to discuss maternal positioning. For some moms, when they lay flat when they're pregnant, the uterus compresses the inferior vena cava into a lesser amount the aorta. This is referred to as supine hypotension syndrome. An older term would be aortocaval compression syndrome. However, because of this compression of the great vessels, we can drop the cardiac output by up to 25%. However, treatment is simple with leftward positioning or uterus displacement. As you can see here, as mom is turned to her left, it decompresses the inferior vena cava and the aorta, improving forward flow, increasing venous return, and reestablishing baseline cardiac output. There's various ways in which you can achieve this. As you can see in this example, mom's helping us a bit with some leftward positioning while the provider is offering some uterine displacement to the left. In this example, mom isn't able to help much. The provider comes to the left side of the bed and provides extreme uterine displacement to the left. And then lastly, in this example, it appears that mom is undergoing CPR or ACLS and is still on a backboard. The provider is wedged up the backboard to provide leftward positioning. Next, let's talk about tocolytics. And the way I think about tocolytics are anti-contraction drugs. So they're given to delay labor. And really the medications you have to deal with in the US would be indomycin, nifedipine, magnesium sulfate, and terbutaline. And this can be remembered with the mnemonic, "It's not my time." So once again, it would be indomycin, nifedipine, magnesium sulfate, and then terbutaline. Terbutaline is used to a lesser extent in the US in regards to a tocolytic medication. Now let's move on to magnesium sulfate. So magnesium sulfate has multiple uses. It's cheap, it has low toxicity, and when it does become toxic, it's very easy to reverse. We can use magnesium sulfate as a tocolytic. We can use it empirically or prophylactically in preeclampsia, or we can use it for direct treatment in eclampsia and seizure. Pretty easy to remember the dosing. It's anywhere between 4 to 6 gram IV bolus, followed by a 2 gram per hour infusion. In the situation of eclampsia or seizure, a repeat dose of magnesium at 4 grams IV before any other anti-epileptic medication is given. It's important that we conduct a thorough exam when we're administering magnesium sulfate. We want to look at the level of consciousness, the deep tendon reflex. We want to monitor urine output and also pay special attention to the respiratory rate and the depth of those respirations. Clinical indications for magnesium toxicity would be lethargy, hyporeflexia, low respiratory rate, or weak reduced pulmonary excursion. Now, we can check therapeutic levels for magnesium. Most folks would reserve this for patients that have a low or questionable urine output, acute kidney injury, or have history of chronic kidney disease. If you are to check a magnesium level, the therapeutic range is between 4 to 8 milliequivalents per liter. However, most experts would agree that a higher level between 6 or 8 milliequivalents per liter is more appropriate. Now, what if you do identify magnesium toxicity? Well, it's very easy to reverse, and we'll reverse that magnesium toxicity with IV calcium. Now let's move on to betamethasone. So betamethasone is a glucomineral corticosteroid, and it crosses the placental barrier where hydrocortisone and methylprednisone do not. Betamethasone is administered to accelerate the fetal organ maturation, and this accelerates the pneumocyte maturation, it improves lung mechanics, and it increases surfactant production. The overall teaching with betamethasone is the sooner the better. This isn't going to be a medication that you give and it's going to be effective in 2 hours. The benefit on fetal organ maturation takes anywhere from 2 to 7 days. The timing indication for betamethasone is somewhat debated in the obstetrics community. It's safe to say that it's recommended if the gestational age is less than 34 weeks, and it's considered if the gestational age is between 34 weeks and just shy of 37 weeks. In doing so, we know that it reduces respiratory morbidity of the fetus. A relative risk reduction is 0.66, decreases ICH, decreases necrotizing enterocolitis, and most of all, decreases death with a relative risk reduction of 0.69. Moving on to uterotonics. So uterotonics stimulate contraction of the myometrium. And yes, they can be given to induce labor, and sometimes you do see that in the ICU. But the mainstay of the use of these medications in critical care areas are to treat uterine atony. As you can see here, if you have a weak, boggy uterus, the myometrium fails to contract. It fails to tamponade those spiral arteries that are bleeding, and it allows for wide open hemorrhage. We need to do everything we can to cause a myometrial contraction, that uterus to tighten up, to tamponade bleeding. And one of the ways to do this is administering uterotonics. More common medications in the United States is oxytocin and methergin. So now let's move on to the disease process. We're going to cover hemorrhage, preeclampsia, eclampsia, HELLP syndrome, sepsis, venous thromboembolism, and amniotic fluid embolism. And this will really be a lightning round discussion where I only superficially discuss the pathophysiology, diagnosis, and treatment of these different disease processes. These discussions, will function as the first building blocks improving depth of knowledge, and it can be built on at a future time. First, let's take a look at hemorrhage. So hemorrhage is one of the major causes of maternal mortality, and uterine atony is one of the most common etiologies of hemorrhage. In addition, due to the high numbers of C-sections seen in the US, this can lead to significant increase in inherent placental disorders that are related to hemorrhage. We'll discuss this very shortly. ACOG, the American College of Obstetrician and Gynecology, defines hemorrhage as greater as 1 liter blood loss. It defines major hemorrhage as greater than 1.5 liters blood loss. However, during a vaginal delivery, anything greater than a half liter should define hemorrhage as well. And we're pretty bad at estimating blood loss. So it's very important that we're weighing all our sponges during vaginal deliveries and operative procedures. The uteroplacental unit at term, the blood flow going through that placenta is in the upwards of close to 1 liter per minute. This is shocking. This is an amazing amount of blood. So the potential for hemorrhage is always there. Under normal conditions, the uterine artery feeds the myometrium, and then subsequently there's 120 spiral arteries that help perfuse the endometrium and placenta. During delivery, the placenta tears away from the uterus, the spiral arteries retract, the myometrial contraction tamponades out those spiral arteries, and then the coag system activates and plugs the spiral artery bleeding. However, there's a multitude of opportunity for this process to go wrong. So let's explore our causes of obstetric hemorrhage, and this really can be defined into 4 groups, the 4 T's. We have tone, tissue, trauma, and thrombin. Tone can be thought of as uterine atony, tissue can be thought of as retained products or different forms of placenta implantation issues. Trauma can be defined by cervical or vaginal lacerations, and the last 4T, thrombin, is a good way to remember coagulopathy. So now let's take a brief minute to take a look at these placental disorders, these placental implantation disorders. First, we have placenta previa. Here you can see in comparison to the normal location of the placenta, in placenta previa, the placenta is covering the cervix right where that fetus needs to come out. This leads to inherent problems related to hemorrhage. Then we have placenta eruption. In comparison, you can see the normally attached placenta. Unfortunately, here you can see the premature detached placenta, and this could be from trauma, from drugs, and most certainly hypertension. And then you have the placenta cretas. So first you have placenta accreta, and that's where the placenta infiltrates the myometrium by less than 50%. Then you have placenta increta, and that's where the placenta invades the myometrium by 50% or greater. Then lastly, you have placenta paracreta, and this is where not only does the placenta invade the myometrium, but it also penetrates outside the myometrium into surrounding tissue. All the placenta cretas can lead to life-threatening hemorrhage. This is another opportunity to highlight the importance of good prenatal care. These disorders can be picked up on routine ultrasound, and this allows for the obstetrician to prepare for a surgical delivery plan. One of the suspected reasons these disorders are being seen more is the higher amount of C-sections in the United States. C-sections leave scarring of the uterus and make them more prone to these implantation issues. So how do we treat obstetric hemorrhage? So first, as discussed, we have our uterotonics. Then we can do fundal massage. We can do bimanual massage. If this is refractory, the obstetrician can insert a intrauterine balloon. If still refractory, if mom isn't opened up, she can be surgically opened up and the obstetrician can place compression sutures. There's multiple variations of this, but the one seen in the picture is the B. Lynch method. And if mom continues to bleed, there's a possibility of uterine or ovarian ligation. We can send the mom down to IR for uterine embolization. And the last salvage attempt to stop bleeding would be a full hysterectomy. Mom sustaining life-threatening bleeding with greater than 50% of her blood volume being lost, so a massive transfusion protocol needs to be triggered. This is an emergent blood transfusion with equal parts packed cells, FFP, platelets, and to agree, cryoprecipitate. Now let's move on and discuss preeclampsia. Now, preeclampsia is one of the major causes of maternal death worldwide, and a discussion of the pathophysiology of preeclampsia is well outside the scope of this lecture. But for time purposes, let's just say that preeclampsia is a result of placenta and maternal vascular dysfunction. And knowing this, cytokines and endothelial reactions occur that cause hypertension and a vast amount of symptoms. These symptoms include headache, blurred vision, epigastric pain, pulmonary edema, placenta eruption, just to name a few. In pregnancy, hypertension is defined as a blood pressure greater than 140/90, and severe hypertension is defined by a blood pressure greater than 160/110. Now first, we need to have a cutoff for hypertension of 20 weeks. If the hypertension occurred before the 20 weeks, it's chronic hypertension. If the hypertension occurred after 20 weeks, then it's gestational hypertension. So how do we diagnose preeclampsia? We diagnose with symptoms, We diagnose with the findings of hypertension. In the setting of a blood pressure greater than 140/90, we need to find proteinuria. However, in the setting of severe hypertension, greater than 160/110, if we have end organ dysfunction and severe symptoms, we do not need proteinuria to diagnose preeclampsia. Now, how do we treat preeclampsia? Magnesium sulfate. So again, we do a 4 to 6 gram load, and then we run an infusion at 2 grams per hour. Then we need to address the hypertension. The mainstay medications are labetalol and nicardipine. We want a blood pressure reduction no more than 25% in the first 24 hours. Always take special caution with labetalol. It's a non-selective beta blocker. You need to watch it in your asthmatic patients. And then secondary medications would be hydralazine and nifedipine. Preeclampsia is a placenta problem. The only way to definitively treat preeclampsia is getting rid of the placenta. This is where the expertise of the obstetrician really comes into play. If we're able to stabilize mom and control her blood pressure and symptomatology, most likely the obstetrician will start giving betamethasone and try to delay delivery. Now, how about eclampsia? So first of all, what's the difference between eclampsia and preeclampsia? And that answer is a seizure. So preeclampsia plus a seizure equals eclampsia. So how do we treat this? So first, with any seizure, we treat the ABCs. Then next, remember, we're treating eclampsia, we're treating pregnancy. Instead of reaching for that lorazepam, we're going to repeat a bolus of magnesium, another 4 gram IV bolus. If they're refractory to that, then you can reach for your benzodiazepines, and then you treat seizures in a normal common sense, and you move forward with anti-epileptic drugs. And if that's failed or refractory, you intubate and start propofol and or barbiturate. Now, before moving forward, I want to make a couple points. Eclamptic seizures are self-limiting. If you have a refractory seizure of an obstetric patient, I ask myself 2 questions. Do they have a history of seizure, epilepsy? That's to be treated in a different standard. The answer is no. We really have to start worrying about intracranial hemorrhage, especially in the setting of hypertension. And this is when we send our patient for a CT head to rule out differential. And lastly, once eclampsia is diagnosed, delivery needs to follow irrespective of the gestational age. Now let's move on to the HELLP syndrome. HELLP stands for hemolysis, elevated liver enzymes, and low platelets. Again, for time purposes, we can't go through the proposed pathophysiology, but there seems to be some association with preeclampsia. HELLP syndrome is defined by a microangiopathic anemia and activation of the coagulation cascade. Let's see what that looks like from a laboratory and a clinical perspective. So HELLP syndrome is defined by hemolysis, and we see this in an anemia, hemolytic anemia. We'll see schistocytes on the CBC differential. The next criteria is a transaminitis, greater than 2 times normal, followed by low platelets. That's less than 100,000 when it comes to pregnancy. And then lastly, we'll see the development of coagulopathy. Clinical findings are very similar to preeclampsia, including hypertension, blurred vision, AKI, proteinuria, pulmonary edema, liver hematoma, and petechial hemorrhage. Now let's move on to sepsis. So when it comes to worldwide deaths, it's the 3rd most prevalent cause of maternal mortality. And how we define or how we diagnose sepsis in pregnancy is somewhat difficult. Sepsis 3 definition, SIRS, SOFA, all these have shortcomings when it comes to a pregnant woman, given their softer blood pressure, their creatinine differences, their increase in heart rate, and increase in white blood cells. The World Health Organization defines maternal sepsis as a life-threatening condition involving organ dysfunction from an infection throughout pregnancy, childbirth, post-abortion, or postpartum period. We can see etiologies of sepsis both rooting from obstetric sources and non-obstetric sources. Obstetric examples would be chorio, endometriosis, septic abortion, pelvic abscess, and mastitis, while we see non-obstetric examples too, seeing pyelonephritis, pneumonia, appendicitis, and cholecystitis. There's several discussions to be had when we're treating a pregnant woman in sepsis. So first of all, the Surviving Sepsis campaign advocates 30 mL per kilo of crystalloid resuscitation. It's unknown if this is appropriate in a pregnant mom, especially considering their total body water excess. This also causes their body weight to be greater than what their ideal body weight is. So there's always a concern for fluid overload. Norepinephrine is the first-line vasopressor. Normally in sepsis, we use vasopressin as the second-line vasopressor. However, you do not use vasopressin in pregnancy because it can cause contractions and early labor. Hopefully, the majority of our pregnant women are healthy and young. There's a lower risk for multi-drug resistant organisms, but we always need to be on the watch. Generally, we worry about group A strep, E. coli, and polymyx infections. Broad-spectrum antibiotics for an obstetrician would be ampicillin, gentamicin, and clindamycin. The ampicillin is to treat E. coli. The clindamycin is to take care of the toxin production from the group A strep. And the clindamycin is added because we know that there is some ampicillin-resistant E. coli. Now, when a patient gets in the ICU, we can do this coverage very appropriately with piperacillin tazobactam and probably vancomycin, and appropriately de-escalating our antibiotics on a day-to-day basis as we do with a normal patient. We generally want to avoid fluoroquinolones, not just in the generalized ICU population, but also in pregnancy because we worry about fetal development of cartilage. We also want to take caution with aminoglycosides for all the normal reasons we do in the ICU, but also with a pregnant woman, we worry about fetal nephrotoxicity and ototoxicity. Now let's move forward to venous thromboembolism. So make no mistake, pregnancy is a hypercoagulable, antifibrolytic state. It's a state of making blood clots and not breaking them down. Pregnant women have an increase in 2, 7, 8, 10, and 12 coagulation factors. They have decreased fibrolytic activity and they have decrease in protein CNS. This makes them 4 times more likely to develop a VTE than a non-pregnant patient. And we always need to remember Virchow's triad. So we have a hypercoagulable patient, there's stasis of blood flow, so we at least have 2 out of the 3 of the triad. The tools that we use to diagnose VTE would be ultrasound, chest x-ray, D-dimer, CT of the chest, and echo. Always remember a D-dimer is going to be high in a pregnant woman. Here's an example of a diagnostic algorithm for a pregnant woman. This is derived from the YEARS algorithm and also a paper termed the Artemis trial from 2019. If you have a patient with a high suspicion of PE, you first get a chest x-ray. From that chest x-ray, you might find other pathophysiology that dissuades you from a pulmonary emboli. This could be a pneumothorax, pulmonary edema, or pneumonia. You treat those folks. If you still have suspicion or you find a wedge infiltrate, then you go over and you order a D-dimer and you're going to assess for YEARS criteria. YEARS criteria is clinical signs of a DVT, hemoptysis, or PE is the most likely diagnosis. Follow our arrow down and you can see our decision tree. You have no YEARS criteria. And your D-dimer level is less than 1,000, PE is ruled out. Next, you have no YEARS criteria and your D-dimer is greater than 1,000, you need to go for a CT chest. Following that, YEARS criteria, you get 1 out of 3 and your D-dimer is less than 500, you do not have a PE. And then lastly, you have 1 to 3 YEARS criteria and your D-dimer is greater than 500, you need to go for a CAT scan. Now for me, with dealing with a pregnant woman with a VTE, there's 2 scenarios. There's mom that has a little chest pain or shortness of breath but is hemodynamically stable. Then there's a mom that's suffering hemodynamic consequence. If we have a hemodynamically stable mother that's not showing any evidence of isolated right heart failure, we can try to rule out a DVT. Because if the DVT is positive, we can stop, we can anticoagulate mom. We really don't need to go forward with diagnosing of a PE because it's not going to change management. However, if that mom is demonstrating hemodynamic instability or isolated right heart failure, then we do need to continue and rule them out for PE with a CTA. So to summarize, if you have a hemodynamically stable mother and you find a DVT, stop, anticoagulate, no need to rule out PE. If you have a mother that's suffering hemodynamic consequences, then you need to push forward and use the YEARS criteria with the D-dimer cutoffs to understand if they need a CTA. So once diagnosed, how do we treat a venous thromboembolism? And the answer really is low molecular weight heparin. And this is really the preferred option for all PEs, unless you have bleeding risk or you're going to undergo an aggressive intervention. When it comes to pregnancy, we are balancing a lot. There may be bleeding, procedures, timing of delivery or C-section. They might need to get an epidural. So you might see heparin infusion with this situation as well. But preferred, if no contraindication, would be low weight molecular weight heparin. When it comes to warfarin, absolutely not during pregnancy, but it is safe during lactation. And then phenyldiperin, drug thrombin inhibitors, and 10A inhibitors are contraindicated in pregnancy. And this is merely most likely just because that pregnancy is an exclusion criteria in the majority of trials. Now, if mom has a high risk / massive PE, TPA, tissue plasminogen activator is indicated. It is appropriate for pregnancy. It does not pass the placental barrier. Now let's move on to amniotic fluid embolism. So these are uncommon, but they're very deadly. The majority of the cases lead to cardiac arrest, and the mortality is awful. Of the folks that do survive, there's a high incidence of neurological impairment. It's seen in the presence of sudden, unexpected hypoxia and shock, and my differential immediately goes to amniotic fluid embolism or a massive high-risk PE. What divides this differential? The presence of coagulopathy / DIC should push you right to amniotic fluid embolism. Amniotic fluid embolism, it's not an embolism that's occluding blood. It's actually amniotic cells that enter the maternal circulation. And this happens to a lot of women, but only certain ones suffer this condition. It's actually a humoral or immunological process. So for all intents purposes, it's anaphylaxis. So this causes an increase in PVR, pulmonary vascular resistance, and causes a right heart failure that subsequently causes hemodynamic demise. This can occur anywhere in acute labor up to about less than 30 minutes postpartum. postpartum. Most experts that are studying this actively have changed the name to anaphylactic syndrome of pregnancy. So how do we treat this? Well, we really don't know. A lot of the reports are case series or case studies. Of course, we should tend to the ABCs, initiate ACLS. If mom has not delivered yet and she's coding, an emergent resuscitative hysterotomy is indicated within 4 minutes. We need to treat hemorrhage, treat coagulopathy, and supportive care. We need to be ruling out differentials, aortic dissection, anaphylaxis, a big MI, pulmonary embolism, air embolism, or hemorrhage. We need to provide careful fluid resuscitation in those patients that demonstrate fluid responsiveness. We need to replace blood if the patient is bleeding. We need to reverse coagulopathies. We most likely have to provide vasopressor or inotropic therapy. This would revolve around norepinephrine and epinephrine. There's some talks and case series, case studies about corticosteroids or plasmapheresis. And lastly, due to the hemodynamic compromise, we always can consider VA ECMO, venous arterial extracorporeal membrane oxygenation. So let's wrap this session up. The most important objective of this whole education session was really to understand the drastic physiological changes during pregnancy. And once we have that normal physiology understood, we then can recognize the pathophysiology that follows. I want to close by reiterating the quote, "The woman remains the primary patient and fetal concerns cannot be allowed to compromise her care." That concludes this educational session on critical care obstetrics. Thank you for your interest in this session. As always, please email me if you have any questions or feedback. Thank you.